Welcome everyone to tonight's event. We're going to let everyone join the event here and we'll start in just a moment. Welcome everyone to tonight's event, Race, Gender, and Bias in Medicine, Experiences and Insights. My name is Nate Olson. I'm the Associate Director of the KIE Institute of Ethics here at California State University, Bakersfield. We're very excited for this evening's event, which is the second event we've had in our KIE Institute of Ethics, Kaiser Permanente, Bioethics, and Medical Humanities series. Excited to partner again with Kaiser Permanente with this event. And to start this evening's event, I'd like to turn things over to KP's Area Medical Director for Kern County, Dr. Marvin Campos.
Thank you, Dr. Olson. So good evening, everyone. KP is a proud sponsor of the KIE Institute of Ethics since 2010, and we strive to bring forth forums and topics that address the importance of ethical living and decision-making as part of a healthy community. Kaiser Permanente has a long history of supporting the Institute as one of the largest corporate contributors. And equally important, we have senior leadership and local Kaiser Permanente physicians serving on the board as board members for the Institute for many years. David Womack, our Senior Vice President, is the current chairman. And when his tenure expires, I will be proud to join the KIE Institute of Ethics Board in his place. This evening's panel includes several amazing presenters on race, gender, and bias in medicine. It is sure to be thought-provoking and will reinforce the importance for each of us to commit to being open and honest with ourselves in order to affect real change in our community and in the pursuit of medical ethics. Thank you, Dr. Olson.
Thank you, Dr. Campos, and welcome to the board, the KIE Institute board. Okay, so just to say a little bit about tonight's event. So tonight's event, we'll have a moderated conversation with our three expert panelists. That will take about the first 45 minutes or so of tonight's event. After that, the panelists will be answering questions from you. If you look at the bottom of your Zoom window there, you can see there's a Q&A button. If you press that Q&A button, you can submit questions at any point during tonight's event. I'll then pose these questions to the panelists during the question and answer period after our initial conversation. Also, after the initial conversation, we're going to post a survey link for all attendees. Please complete this to provide us some feedback on the event. And for those of you who are attending the event and receiving continuing medical education credit, CME or CEU credit for tonight's event is accredited for that. And you can receive that certification or your CME, CEU credit by completing that survey. Okay, so from here, I'm going to turn things over to moderator for tonight's event, Ms. Brittany Johnson. Brittany Johnson is a senior philosophy major here at CSUB and one of our inaugural KIE Institute of Ethics Student Fellows. This academic year, she has focused her fellowship on the topic of bias in medicine, including writing her senior thesis about it. After Brittany graduates, she plans to pursue an MD as well as a PhD in philosophy, continuing to study the issue of healthcare disparities. Thank you, Brittany.
Thank you, Dr. Olson, and hello to everyone, and thank you for attending tonight. Our guests that we will have this evening are our panelists, and that is going to be the illustrious Dr. Sharon Okonkwo-Holmes, Dr. Keisha Ray, and Dr. Kateena Addae-Konadu. Dr. Sharon Okonkwo-Holmes works at the Kaiser Permanente Panorama City Medical Center, where she cares for patients living in an underserved area of the San Fernando Valley. Dr. Okonkwo also serves as Language Concordance Physician Champion and her medical center's Equity, Inclusion, and Diversity Physician Champion. Dr. Okonkwo is also an instructor in the Department of Clinical Science at the Kaiser Permanente Bernard J. Tyson School of Medicine. Our other guest, Dr. Kateena Addae-Konadu, is currently a physician and fellow of maternal-fetal medicine at Duke University Medical School. A proud HBCU grad, Dr. Addae-Konadu has received numerous awards and honors in her career as an MD PhD. She has also presented on the impact of imposter syndrome in training and careers in medicine, among other topics. Among our panelists as well is Dr. Keisha Ray, who is the assistant professor at the McGovern Medical School in Houston, Texas, with their Center for Humanities and Ethics. Dr. Ray's work focuses on the social determinants of racial disparities in health and healthcare, and also on how to incorporate race education into medical school curriculum. Thank you, ladies, for coming, and I really appreciate your presence here tonight. And for everyone attending, our panelists do have a lot of experience in bias, medicine, and the intersections of race and gender. So let's get into it, ladies. I'm so excited to be here. For our first question, which is going to be for all, but if Dr. Addae-Konadu could answer first, what was one event or inspiration that helped lead you into medicine as a career? And also, while you're thinking about that, what's one challenge that you faced on that path?
Yes, thank you for that question, Brittany. While I've always had an interest in medicine, my decision was solidified after being selected as a Hubert Scholar at Agnes Scott College in Decatur, Georgia. This was an externship that paid for you to go anywhere in the world to provide humanitarian aid. I had previously done some work with families affected by HIV/AIDS in high school. So based on that experience, I decided to spend the summer working in Arusha, Tanzania, teaching HIV and AIDS prevention in the Maasai Community Center and providing aid to families affected by HIV. And Arusha at that time, about 1 in 4 people were infected with HIV, which had a devastating impact on the community. And as a female in a mostly male-dominated society, I felt my voice was often unheard. So I thought, as a medical provider in this particular setting, there was only so much I can do in that particular community. But if I was a part of a research team that discovered a vaccine or a new therapeutic agent, I can impact lives that I may never encounter. So that eventually led to a T35 NIH research fellowship during the summer of my 3rd year in college, and my ultimate decision to pursue the MD PhD track. As for challenges, in my senior year of college, I approached my pre-med advisor to discuss my plans for pursuing a career in medicine. And I asked this advisor about his thoughts on me applying to medical school. And he felt that I would not be a good candidate. Mind you, I had decent grades, had multiple scholarships, as well as research experience. I then asked about pursuing a PhD. He also said no to that too. I finally asked about pursuing a master's, to which he said I shouldn't consider a career in medicine or science. Needless to say, despite that advice, I was accepted into several medical schools, ultimately enrolling at the Morehouse School of Medicine in Atlanta, Georgia, where I graduated with an MD, a PhD in biomedical science, and a master's of science in clinical research simultaneously. The first to do so in the history of the school with several national graduate awards and presentations. I share this story to demonstrate that it is important to consider the source from whom you receive advice, and to weigh that advice carefully against the evidence presented to you and your own gut intuition before making a final decision. The advisor can be well-intentioned or harbor implicit bias, but you should not let that deter you from your vision or plan you have for your future.
Thank you. Thank you for answering that. And speaking about bias, that brings me to Dr. Keisha Ray, who has done a lot of work in implicit bias as well. And since one of our main topics tonight is bias, Dr. Ray, people can mean so many different things by bias. And as an expert on this issue, what do you mean by bias? And are there different types of bias?
Sure, yeah. So biases to me are when we have certain kinds of preferences or even certain aversions to different groups of people, different kinds of people. And normally it's because of a stereotype or some sort of negative belief that we hold about individuals in that population. And typically when we talk about biases, we talk about unconscious biases, those that we are not aware of, those that are really, really ingrained in us. And even sometimes these unconscious beliefs can even go against what we think we believe, or even go against our values that we think we hold. And then you have, of course, the conscious ones, the ones that we are fully aware of that we have, right? And what's really important about biases is that we can have them towards all different kinds of people. We can have biases about fat people, about transgender people, about people of color, about women. We can have biases about poor people, right? And what's important about them is that biases lead to discriminatory behavior. Right, so when you have a bias, that can then lead to racism, sexism, ableism, that kind of thing. So one example that might be relevant that we see sometimes in my study of Black maternal mortality is that you see that providers will have certain biases about Black women, right? Some of them have to do with sexual nature, right? Thinking Black women are lustful or over-sexualized or fit this Jezebel trope, right? And then that can then lead them to have perform discriminatory behavior, like providing them less care or comfort while they are pregnant or while they are delivering, right? Because they have these deep-seated values about the nature of women, Black women, the nature of why they ended up pregnant, you know? And so that is one of the causes that we see for Black women having higher rates of Black maternal mortality, are these biases that then lead to discriminatory behavior against Black women.
Thank you, Dr. Ray, and thank you for that definition on implicit bias. And I love how you also worked into the maternal morbidity, which is also kind of what I researched this year as the KIE Student Ethics Fellow. So thank you for bringing that into the conversation. Dr. Okonkwo, because we are talking about bias in medicine and maternal morbidity, you work as a family physician. So what would you say is bias in the medical setting or context?
So I would say that, you know, I think it's, first of all, it's important for all of us to recognize that if we have a brain, we have a bias. So I always begin by just normalizing that. You know, if I have a brain, I have a bias. And when we think about biases, they weren't always so bad, right? So biases were present for us from the time of our ancestors because, you know, they served to protect us as we hunted, as we gathered, as we interacted with different villages and different people. They were very important for us to know good versus bad, mainly in-group, out-group. And so to this day, we have this very important similarity bias that we cannot help. It comes within milliseconds. You know, if you see something that is similar to you, there's an affinity for it. So think woman, you know, it could be quite honestly be anything. And what I like to do is I first like to normalize it, and then I like to explain that knowing that we have a bias is only half the battle, if that. The next step really is to be a courageous and be an inquisitive and curious leader, which might entail getting to know what your biases are. So putting a name on your bias. So for me, I took several Harvard Implicit Association tests, the IAT test. And when I finally was able to sort of label my biases, after being quite frankly shocked by so many of them, because, you know, you think that there's no way I could be biased against this because I'm that. Then I was able to start an exercise that I teach everyone to do, which is stop, label the bias as you find it to be triggering, and then really interrogate it. So when I interface with my bias, whether it's as I practice healthcare or as I'm walking down the hallway or as I'm interfacing with anyone in the community, I stop, I label it, I notice the discomfort that follows it, and then I interrogate the validity of it. And when I find that there isn't any validity in it, I really choose to reject it. And then I look again at that person and I can see them from a different lens. So yes, bias is present everywhere for every physician who sees any patient. And I think what's most important is not making it taboo, but normalizing it and coming up with these exercises to sort of combat it.
Absolutely, absolutely. I love how you work that in about testing it and testing yourself as someone who works in the field to know about the different biases that you yourself may hold. And there's so much research being done right now on healthcare disparities and implicit bias. Like I mentioned, I myself as a student fellow have done research into how health outcomes can be impacted by the implicit bias of a physician. So I feel like tonight's really important conversation. So I thank you ladies for your input. To move on about the way that bias works in medicine, Dr. Kateena, you are a fellow in maternal and fetal medicine at Duke University School of Medicine. So it's a highly stressful environment working in obstetrics. And as a Black woman, even more so, how have you encountered bias or how have you viewed bias as a fellow at Duke?
Yeah, thank you for that question. So, and my observation and experience, I think bias in medicine can be seen in multiple forms, including being passed over for promotions despite a qualified resume and experience, while observing individuals from the majority group who may be less qualified or less senior receiving a similar promotion or more resources for career advancement. It can be displayed as having your medical decisions questioned more often than your majority counterparts, or feeling the need to constantly provide evidence for your medical decisions before it's accepted. Conversely, your majority colleagues can recommend a decision that is not evidence-based, but based on their own clinical gestalt. And I'm not saying that that's wrong, but it's often accepted without question. Having your presence viewed as meeting a minority quota and not because you're qualified to be there. I believe that this leads to the feeling of being an imposter, which can manifest in many ways, including anxiety, second guessing yourself, and internalizing these external viewpoints, which make you question your own sense of belonging. Not being referred to as a doctor, but instead by your first name and in a professional setting or in front of a patient. Feeling a sense of uneasiness when you enter the room of a majority patient and their family members, when you introduce yourself as a supervising physician. I strongly feel that this is where emotional intelligence really becomes key in recognizing the change in the tone and the change in the body language. Once I personally sense this, I usually pull up a chair to the bedside, and I discuss with the family the pathophysiology of the presentation and the evidence to support the clinical management plan. I also patiently answer any questions they may have, and in my experience, this really goes a long way, and it helps to melt away any doubt or concern. However, I think it's really important to note that no matter how hard you try, your approach may not work, and sometimes it's not either a good fit based off of presentation style, or the family just isn't comfortable. But instead of taking it personally, which I know can be easier said than done, offer a second opinion, because at the end of the day, what is most important is providing excellent patient care and keeping the patient at the center of the circle. Lastly, all these scenarios, including micro, macro aggressions, can become exhausting and make one question their decision to remain in academic medicine. During these times, I think it's paramount to remember why you entered medicine in the first place. Also remember those small wins you've had in the past. That could be academic awards. It can be making life-saving medical decisions, because that's what keeps you afloat. It's also important to remember that self-care and self-grace is crucial to personal longevity and decreasing burnout.
Thank you. Absolutely. I also really liked how you touched on patient-centered care, which brings me to our next section where we're talking about bias in medicine. The COVID-19 pandemic has opened a lot of old wounds for our country and has highlighted a lot of fissures in our history as a country. But it's also shown the ways that we've failed as a country, not just minorities, but women in health as well. And I kind of wanted to spend some time with you ladies talking about that, because you all have experience in maternal medicine specifically. In your experience, how has COVID-19, the pandemic, created, or has it highlighted the different disparities that exist for women in medicine? Dr. Kateena Addae, I'll turn it over to you, but Dr. Ray and Dr. Okonkwo will get your answers ready. We're coming to you as well.
Great.
I think patients, that brings to mind the situation with Dr. Susan Moore. So I think patients in the minority group can oftentimes be labeled as difficult when they ask questions about their medical plan. However, what I think most important about this point is that it doesn't matter if you have medical training or not. Studies have shown that, despite your socioeconomic status or level of education, people in the majority group still receive subpar care at times. And speaking of COVID-19 specifically, the tragic story of Dr. Susan Moore, who was hospitalized with COVID-19 in November 2020 and received subpar care despite her medical background and questioning of her plan, leading her to reach out to social media in desperation just to seek help. She eventually was discharged hypotensive. She was hypoxic, and she was subsequently admitted to a different hospital that same day, where she clinically decompensated and died. And she was only 52 years old. So I think that, that situation itself really highlights that disparity we see, COVID-19 kind of placing a spotlight on the disparities we see in medicine.
Thank you. And ladies, same question. So Dr. Ray?
Yeah, I think what COVID-19 has really showed us is what our actions will be when we perceive a scarcity of resources. So when there's a scarcity of resources, including things like testing, like COVID-19 tests that were, scarce at the beginning of the pandemic, it really shows us how our biases can make us prioritize some people and deprioritize other people. And especially in the beginning of the COVID-19 pandemic, but even now, you can see a lot of our biases against certain groups driving policy, driving the way that we allocate resources, whether that is to people who are disabled and we're using our biases there, or to even Black people. We have the story of, Miss Mungan, a New York City teacher, Black woman, couldn't get a COVID test to save her life. And unfortunately, she did pass. She was told that her symptoms were because of anxiety. It's something that's commonly told to Black women when they complain of discomfort or pain, or they try to tell caregivers something's wrong, and telling them it's anxiety or it's all in their head or they're mistaken or take some aspirin is just another way of silencing Black women, really. And so we're seeing that, especially when there's a scarcity of resources, we start to rely on these biases to allocate resources. So we're seeing that. And then, I'm first and foremost a philosopher and a bioethicist. And so I also study these things, and you're also seeing these other ways that COVID-19 is making it worse for different racial groups, particularly Black women. You're seeing that COVID is worsening things like inequities in access to housing, inequities in access to jobs. So right now, the group of people who are most affected in terms of being evicted from their housing are Black women. They're feeling the brunt of housing insecurity caused by COVID-19, joblessness caused by COVID-19. And so you're seeing ways that COVID-19 is sort of highlighting things. Housing has always been an issue for Black women. That's nothing new. Access to equity and income has always been an issue for Black women, but COVID-19 is sort of making it worse. Provider bias has always been an issue for Black women, but again, we're seeing it more, and then we're seeing it on a larger scale. So more people are talking about it, and webinars like this are really highlighting the issue and bringing more people to the issue to know about it. And I think that's how we ultimately can start to help the problem.
Absolutely, I agree. Dr. Okonkwo, would you care to weigh in on the pandemic and highlight disparities?
Sure. Honestly, when the pandemic became a real reality for most Americans, I have to say that I was especially concerned. I was especially concerned because even earlier on, I could see that there was something very, very funny happening with with two things. Number one, with racism and xenophobia against Asian Americans, that was very rampant, and I had to speak to that. But then quickly, I noticed that there was this disparity in who was dying of COVID. And so I knew that I fit the description of someone who was most likely going to die of COVID if I got this deadly vaccine, and or my family members. And it made me very, very afraid for them. And the reason why I say this is, I'm watching CNN and I'm listening to presidential presidential candidate Andrew Yang, and he's talking about that it happened to him, that he was just shopping for the bare basics like any other American, and he came across the empty aisle, and all eyes turned on him, and quickly he felt it. He thought that all of his success could delete it, but he felt it. And what he felt is something that I feel. I think many of these women feel often, which is that sense of disdain, that audacity that you're here, and that this, quite frankly, is your fault. Didn't help that our administration blamed it on one group over the other. But what I will say is that while that was happening, the racism and the xenophobia against Asian Americans because of COVID, there was another very complex thing happening. And what it was that Black and brown people were dying at an extraordinary rate. And I asked myself why. And quickly I began to realize it goes back to the social determinants of health. The social determinants of health determines who lives where, who works where, right? Are there green spaces in your community? If you're blessed, you have blue spaces, which is the ocean to cleanse a lot of that air. And what I could see was that racism was really playing a big role in not only morbidity, but mortality. And when we think about racism, I love Dr. D'Angelo because she says, this isn't an event that involves one person. This is a system. It's a complex system. And what I noticed was that systemic racism was giving us statistics like in the state of Louisiana, right, that is 30% African American. We found that well over 50% of the deaths were African American. In fact, 70% of the deaths. And so that got me thinking a lot. And one thing I know with certainty is that during periods of stress, we can always count on social stigma and bias to increase exponentially. So there was a social stigma that was happening against, of course, Asian Americans, and the bias that was happening when each of these African Americans that my other two colleagues mentioned enter the hospital, that maybe perhaps they weren't believed, or the instant bias. Again, the bias happens so quickly, it happens in milliseconds. Like, you don't have to be a bad person to have a bias. We all have a bias. And so in milliseconds, we make these decisions that impact people's health. Do I send her home? Do I think she's being a little bit dramatic? I was quite afraid for my health. And I'm very grateful to have gotten the vaccination. And speaking of the vaccination, I think about the fact that because I'm the equity, inclusion, and diversity physician champion at Pan City, I just want to remind everyone that diversity is very kind of like incidental. Like diversity is what we have with every participant listening. We have a huge array of diversity. Inclusion is more intentional. So inclusion is making sure that we all have this sense of belonging, that we feel that our voices matter when we go to the doctor, that our doctor's listening, right? That we can show up as our true self. So that if I'm LGBTQI questioning, I can show up as my true self, I'm not covering. And more importantly, that if I tell my doctor that I really do believe something's wrong with me, that they listen deeply, that they treat me as I would if I looked like their mom, or if I looked like their sister, or if I looked like their daughter, or if I looked like their, someone, their best friend. And so And so those are my takes on, bias and COVID, honestly.
Okay. Thank you so much. You dropped so many gems of wisdom, Dr. Okonkwo. Thank you so much for that.
Thank you.
I love how you were talking about you're the diversity and inclusion physician champion at the Panama City Medical Center. And that brings me to our diversity and inclusion part of our talk tonight. This Black History Month at CSUB, we're honoring Black women specifically. And that's going to be a nod, of course, to our first ever Black and Asian American female vice president in the United States, woot woot. And also it's a way to honor the other phenomenal Black women that have made waves in history and promoted progress. I would take this time right now to just shout out to me as a young Black woman interviewing you amazing Black women about things that are so important in America for all people. It's just great to see people that look like me in the field doing these things and researching. So that brings me to our first question. What person or mentor in your life made you realize that where you are today was attainable? Because for me, my answer would be you three. So I would love to hear from you. Who was the person for you?
I guess I'll go. That's very nice, Brittany. I appreciate that. I'd say I appreciate that there are students out there continuing this work, because you all are really the ones that are going to push this forward. So I am very happy that you're here and happy that you're continuing this work. It really makes me proud to see you here. So for me, I think that, honestly, I have to think about just the women in my family. I come from a family of a lot of nursing, a lot of nurses, people in the medical field, healthcare workers. I have family right now who are healthcare workers and front lines. And it was really, really pushed in my family that education is something that, you can do. If you don't see anyone there like you, you be the first and you make the way for other people. Making sure that, we stay confident in our abilities, and we knew that we had a village behind us and that were supporting us, gave people like me and my family and myself the courage to step into those spaces where there wasn't anyone that looked like me. And that happens all throughout my career, continues to happen all throughout my career, to be in spaces where I am the only woman, or I'm the only Black person, or I'm the only Black woman. So when you're the first of something all the time, it can really take its toll. It can make you doubt that you belong in these spaces. It can make you, it can just take its toll on your mental health. And so knowing that I had these strong women behind me, and I had these educated women behind me, and women who cared about self-care and cared about their family and cared about their careers and cared about other people and cared about public health and cared about the healthcare system and making sure it was good for people who looked like us, that really gave me the confidence to pursue my career and really kind of shape the way that I think about my own presence here. Sometimes I think sometimes we forget that being present in these spaces where no one looks like us can do a lot for other people. It can do a lot for our students who look like us or who may have never had a Black woman professor. As an educator, I know sometimes I won't do anything special. I'll go in, I'll do my job, even if it's a class where we're not talking about race specifically. And there will be a student who says, just you being here give me that little push to finish medical school, or you just being my professor made me feel like I can do this, and it made me feel good. And my Black students and my non-Black students will tell me that too. So we can't forget that our presence is not just about helping Black students, but non-Black students too benefit from us being in these spaces. And so I use the lessons I learned from the women in my family to then be a mentor or just a presence for my medical students.
I would say for me, it is Honor Wolf. I just actually get emotional just thinking about her. She is a maternal fetal medicine physician. She's retired now. She is an ally and supporter of women's rights. She worked at UNC Chapel Hill for a while as an attending there, and then subsequently became the division director of maternal fetal medicine at University Hospital Case Medical Center, where I was a resident. And I'm a proud graduate of, a historically Black medical college. I love my experience at Morehouse School of Medicine. But I spent 9 years, pursuing an MD, PhD in a community where a majority of the clinicians, scientists, educators, nurses, and patients look like me. And so when I matched into this majority residency program, it was quite a dramatic change for me. It was almost shocking. Like I often felt the need to avoid the stereotype of being aggressive, challenging to work with, or a difficult persona. And I felt like a lot of times my tone, often my tone or questioning would be misinterpreted in my intern year. And oftentimes, like me and my co-minority, medical students were left out of things hosted by, majority senior residents. And we often felt singled out, not given the benefit of the doubt. But Honor Wolf, she recognized that, she noticed that, and she stood in the gap. And times where I second guessed myself and doubt myself and felt like I couldn't do this, she said, yes, you can. And was really the driving force for me entering into the field of maternal fetal medicine. And I remember like being on the interview trail for fellowship, and someone posed the question of, what would you, want to be remembered for when your career is done? I thought about honor. I thought about, it doesn't matter how many papers you publish. It doesn't matter how many titles you carry, but what's really most important are the lives that you touched. And she is such a prime example of that.
That leaves me to answer last. And this year was such an interesting year for medicine, with Dr. Corbett at the NIH having such a huge impact on the development of the Moderna vaccination. So I think about Dr. Corbett. I think about the fact that 4% of physicians in America are African American, and 2% of them are women. So I'm part of a field where I'm one of the 2%, but the other 18,000 plus women are, without fail, are women that are truly remarkable. So women like Dr. Ray and Dr. Addae-Konadu, and a woman like yourself, Brittany Johnson, will be a truly remarkable woman. So I don't have any one particular person. I think about the fact that I come from a family with such strong women, but I think of all the mentors. I think of all of the women in medicine who I've looked up to and have always been impressed by. I think I'm confident that I'm speaking for all of those 20,000 women, and I'm saying that we all feel so incredibly blessed to be here in medicine. We can pay homage and honor to someone like Dr. Rebecca Lee, who was the first Black woman, Black physician years ago. And I think what I will say is that what I've learned is that, equity, we will know that we've achieved equity when we can no longer predict outcomes based on one's identity, right? So we will know that we have truly achieved equity when we can no longer predict outcomes based on one's identity. And my hope is that in the future, we'll have equity even amongst physicians who gets in, right? I think about the community that I'm from. My dad came over from Nigeria to go to USC. So I was born and raised in the USC village. I lived in South Central my entire life. I lived, one of my best friends, LaTosha Harlins, was murdered in 1992. That started the LA riots. I lived in a community that was ablaze, with really just so much crying, and I think that as a Black woman, I have to recognize all of the privileges that I've had in order to get me to be where I am today, right? So, I come from a 2-family household. I'm cisgendered, I'm heterosexual, I am Christian. There are all of these things that we have that are truly privileges, that are just really essential to the story of who we are. You know, I think of Henrietta Lacks. This is a Black woman who died of cervical cancer years ago, and whose cells are immortal. She's a Black woman who allows me to be where I am right now. And her immortal cells, even without her family knowing that those cells were taken, have lived for all of these years and actually helped with the development of the COVID vaccination. So I stand on the shoulders of so many women, and so many women who are not Black, honestly, and men who have mentored me and who listened to me. I will say that in my journey, like the other two physicians, you find yourself being the only. When there's only 2% Black women, you know, I mean, you can literally go to the cafeteria and you can be the only. You know, I can go to a physician noon meeting and find that I'm the only. And there's something really interesting about that feeling. Or I can knock on a patient's room and the patient can open the door only to realize that, you know, I'm brown. Maybe they thought I'd be Japanese because my last name's Okonkwo. And I can look at that initial disappointment, and then I can provide them the best care that I give every one of my members. And I can then see that it's a journey, it's a struggle that we're going to have to deal with for the rest of our lives as Black women. But hopefully someday we won't, you know.
I love that. I love how you said that hopefully someday we won't. And I love how you also said there's a sliding scale for determining when we've reached equity, and that's when we won't have to rely on someone's identity to determine their outcome. And with that, which was amazing, Dr. Ray, you are a bioethicist and you work on disparities. That's your bread and butter. So what are some steps you think that we could all take on a broad scale for increasing diversity in the field of philosophy as a fellow philosopher, woo-woo, and Pixie scholar, shout out to Pixie. Yes. What are some things that you think we could do actionable, like for people watching?
Yeah, so to increase diversity in philosophy and in medical school, I will say these outreach programs, but I don't want to make that broad. I don't want to make that abstract, right? They have to be very specific and pointed, right? It can't just be this general outreach where you say we're just going to go out and encourage people to attend, or we're going to encourage people to pursue these degrees, right? It has to be efforts to get them there, but then also efforts to retain them there, which means support. It means financial support. It means mentors. It means emotional support. It means counseling. It means therapists. It means helping them with grant writing classes. It means helping them with dissertation writing classes, right? It means making sure that if they're a medical student, that they have mentors in their specialty, right? So it's more than just the outreach, right? Because that can be very broad. And same with philosophy, like Pixie is a very specific outreach program to increase underrepresented people in philosophy and to help them pursue graduate studies, right? I am a product of Pixie, right? A very pointed outreach program that said we need to increase people of color in philosophy. This is how we do it, right? I had mentors that followed me through my career through that group. Mentors to this day, one that passed away, and Anita Silver is a disability scholar. So these outreach programs have to be not just get them there, but retain them. How do we get them to graduate? And then how do we get them through residency? How do we get them through internships? How do we get them to be an attending? How do we get philosophy students into PhD programs and then actually get them a job in academia, right? If that's what they desire. So it's more of a follow through, I think, is what we need. And it requires financial support. It requires senior scholars, senior physicians to make a dedication to these. It requires institutions to make these goals and to actually want to bring these goals to fruition, right? So it requires commitment, it requires dedication, and frankly, it requires money and resources.
Yes, yes, it does. I wanted to take a moment for everyone that's attending, and if you feel inspired by the conversation that we've been having, please drop any thoughts and questions that you have in the chat. We're going to have Dr. Olson come back in just a few, actually, to read some of those questions, so get them ready. And while you're thinking, Dr. Okonkwo, if you could share, not everyone got a chance to hear the podcast earlier this week, so I would love it if you could share a little bit of what you did during the podcast when the question was raised about what would we need if we had a magical wand that could change our community tomorrow. You shared some really great words. So while everyone's getting their questions ready for us, I would love if you could share that.
So Dr. Burrows asked me if I had a magical wand, what would I do with it? And honestly, a week later, I thought, oh, I should have just answered that. I would really switch bodies up. In other words, I go into the body of, quite frankly, a white male, and a white male enters my body, and I want him to stay there for 1 year, and I will live in his body for 1 year, because it's by us really living each other, walking in each other's shoes, that we can thoroughly understand what it means to be us. And so for myself as an able-bodied person, I'd have to live in someone's body who wasn't able-bodied. But when I answered the question, I thought that if I got a magic wand, I would give everybody the mentality, the spirit, and the soul of nature. And the reason why is, I consider myself to be a deep enthusiast of nature. And when my marathon knees failed me, I took up hiking and cycling and walking. But over the years, I've learned that my yearning to be submerged in nature is not simply because of her beauty, and she's extremely gorgeous, but also because she doesn't discriminate. So the wind on a breezy day blows towards my yard and his without prejudice. The crash of ocean waves soothes my ears, and the sand supports my weight in the same way it does every single one of you listening to my story. And so that's why I thought, if I could only make all of us, if I could give us the bias of nature, of Mother Nature, that it would definitely change my existence. Thanks, Brittany.
Thank you. Thank you so much for sharing that. And thank you again also to the Kegley Institute of Ethics for providing a platform for my research into healthcare disparities, and also into this project as a CSUB Student Fellow. Shout out to Dr. Michael Burrows and Dr. Nate Olson with the Kegley Institute and CSUB. And thank you to CSUB and Kaiser Permanente for this continued collaboration in the Bioethics and Medical Humanities Speaker Series. This is the second installment. The first one was back in September. And so today was really a great continuation of that talk into ethics and biology. I also wanted to thank the audience for attending and engaging with speakers through your Q&A. We see your questions, and Dr. Olson will get to them shortly. I'm so excited to see what you guys had to say. And I just wanted to give a very special thank you to our panelists, Dr. Keisha Ray, Dr. Kateena Addae-Konadu, and Dr. Sharon Okonkwo-Holmes, just for sharing your insights. And thank you so much. So Dr. Olson, I wanted to turn over to you and those Q&A.
Thank you, Brittany. Doing excellent work this evening. We're so fortunate to have you as one of our inaugural student fellows with the Kegley Institute this evening. And thank you to our three panelists for very insightful comments here this evening. We do have a bunch of questions coming in now, and I'm going to start posing a few of those. You can see also in the chat right now, for those of you to claim CME or CEU credit, you can complete that survey. But for any attendee tonight, it's also an opportunity for you to give us feedback on tonight's panel and thoughts that you have about it, or future things in this series that you'd like us to cover as well. So please fill out the survey that's here, that you can see there, the link to it in the chat. Okay, so the first question, there's many wonderful questions here. I don't know if we'll be able to hit every one of them, but many wonderful questions here. The first one, Dr. Okonkwo-Holmes, I think I'm going to pose this one to you. This is from Ashkan Imanzorai, who I think had mentioned about the Harvard Implicit Association test earlier. And this one, the question is about, can that test be used in physician conferences for better SCPMG physician insight into their own biases.
That's right. I encourage everyone on this call to take a Harvard Implicit Association test. It takes 15 minutes, it's free, and there's several of them. So you'll find out your biases as it relates to, gosh, there's so many wonderful topics. And I think that I've tried to sort of see what I could mandate it at SCPMG, and I haven't been successful. But what I will say is I challenge you, the doctor who's asking the question, I challenge you to take a few of the tests and to really think about the results and the answers and to see how that impacts the way you care for members. It was perhaps one of the most insightful things I've done. And again, we can place the link to that in the chat, and it's perfectly free. I do think it should be offered with most physician education sort of opportunities. I have Brooke Cooper, who's also here. She's in charge of physician education, and I'm sure she would agree that we all need to be more aware of our biases. I thought what was really interesting is there was a study done by University of Virginia in 2016, and it showed that several medical students still held the bias that Black skin was thicker, that it had less nerve endings, and therefore that Black people didn't really need as much pain medicine. And I think to myself that, just 50 cell layers, right? My epidermis is like 0.1 millimeter, would change the way you would treat my pain versus someone else's pain. And these are all based on these sort of biases. It's based on history. It's based on Dr. Sims, the godfather of OBGYN, and all of the research and studies he did on African slaves. That's debatable. It's debatable whether or not it was his right to do them on slaves because he owned the slaves. But what is not debatable is that they were very cruel exercises. They did not involve any kind of anesthesia. And yet he did surgery on a woman's vaginas, repairing a fistula between the bladder and the vagina over and over again on 3 slaves, to be exact, for 4 years until he corrected it. I do know that this is in the fabric and the DNA of our medicine. And whether we want to admit it or not, we have biases. And so we have to be aware when we examine patients, when we treat patients, when we see Black patients who are in pain, we have to listen to them. Because we did another study showing that if I get a fracture, I'm less likely to be treated with opiates, as maybe perhaps Nate Olson, who's wonderful, would be. And if my daughter gets appendicitis, she's less likely to get treated with pain medication, adequate pain medication, as one of my mentors, Brooke Cooper, who I adore. So these things are real.
Thank you. So there's another question here. This one is from Erica Harper. And Professor Harper, I think it's a similar question, but she's thinking about not, I think, just the physician kind of way, but thinking about maybe for non-physicians too. And maybe Dr. Ray, if you want to take this question, the question's, what are some ways that you suggest raising our self-awareness of biases we all have?
Sure. So one, I will say, following up with the previous panelists, is first thinking about medical students. So that's where most of my work is. And I think if we're going to end racial disparities, if we're going to minimize biases in medicine, we have to start before people are physicians. I've spoken with high school students who've done these implicit bias tests and talked about biases in medicine with them, right? And they're starting off at 15, 16 years old talking about biases in medicine. They're learning about Henrietta Lacks and J. Marion Sims. And, at 15, imagine the kind of doctor that they can be if they're doing all of this work at 15, right? We do the IAT test with our second year medical students when they take classes on implicit bias. And we talk to them about how implicit biases are going to affect their patient care, and we force them to examine their own biases and to interrogate their own biases. We're starting before they become attendings and in charge of medical students and residents, and before they become educators themselves. So I think it's really important that we talk about biases well before someone is treating a patient and someone is under their care. For people who are not going into medicine, it can be the same way. You can sort of how we talked about panelists at the beginning is think about when you have an aversion to someone, really thinking about the roots of that aversion, right? The roots of that negative belief. If you find yourself instantly reacting, and implicit biases, we all have them, and they're so quick, right? And they're so just ingrained in us as humans. It's a part of human nature. We use biases to sort of group the world and together make sense of the world, right? There's so many things we're taking in with our senses, and that biases were initially meant to help us make sense of all of this information. And so it's not something to be shameful of. And I think that's one big barrier to overcome is people think that if I admit that I have a bias, that it's shameful, or I'm saying I'm racist or I'm sexist, and that it somehow makes them a bad person. You can have biases and still be a good person. But how you become an ethical person is you confront those biases. What are the roots of those biases? Now, how am I going to face them? How can I change them? And one way that we teach our students is about disassociation. So if you have a negative thought, like let's say you believe something false because of a bias, like Black men don't take care of their kids, right? This false belief that research has disproven. But if you believe that about Black men, one way to confront that is to replace that with positive images and positive beliefs about Black men that you see, whether it's Black men that you know, whether it can even be Black men that you see in a movie being a good father, right? You can do this replacement exercises by replacing these negative thoughts with positive images, which is another reason why positivity in media is so important and how it can contribute to our biases. If all you see of immigrants are that they're poor or that they are jobless, and that's what you start to think. But if we can replace those images with immigrants being educators, being taking care of their family, right, you start to change your biases. So I would really say seek out information that replaces those biases. That's just one way to think about it.
Nate, if you don't mind, if I can piggyback on that as well. Just like speaking from like a medical perspective, I think it's well documented that diverse medical teams lead to better patient outcomes and helps to dismantle barriers to care. We know that it helps to reduce the risk of like being boxed into this one way of thinking or one particular type of perspective, which in my opinion will greatly enhance the quality of care for patients of all backgrounds, whether it's patients of varying ethnicities, different socioeconomic status, or members of the LGBTQI questioning community. So, that leads us to like, well, how do we increase diversity in our field? And I think Dr. Ray pointed at that at the beginning of the panel about, pipelines are essential, building successful pipelines from primary school to medical and graduate school, like from a medical perspective. And that's one thing I think Morehouse School of Medicine has done a really great job of doing, of implementing summer programs in the Southwest community of Atlanta, Georgia, to expose K through 12 grades to both science and medicine. In fact, I participated, and a couple of my colleagues participated in several as graduate and medical students. And I think the biggest thing as far as the medical community is concerned is diversity, inclusion, and implicit bias training. I think that's extremely important at all levels to educate the academic medical community. That's from ancillary staff, that's from medical students, that's from residents, fellows, attendings. I think that is something that Duke has been actively working on. In the Department of OBGYN specifically, they've invested in including and establishing diversity and inclusion and implicit bias training across the department. And they've also created a diversity and inclusion director within the department, which I think is really helpful.
Thank you, Dr. Addae-Konadu. The next question, actually, I want to follow up on that, and more particularly, here's a question from Kathy Mitchell, who asks, what can be done to address physician bias in prenatal care of African-American mothers to reduce infant mortality?
And I would say just that. I would say, increasing those pipelines so that you have more physician in color that are in those spaces, providing medical care. I think too, also just training physicians in general, starting from medical school up through residency and fellowship about diversity, inclusion, and implicit bias training to be able to, not get boxed into that one way of thinking, right? And as as Sharon had mentioned before, like thinking about patients not from, oh, this patient doesn't look like me, but what if this was my mother? What if this was my grandmother? What if this is my sister? I would want to provide exceptional care to them. So just like I would provide exceptional care to my family member, I should provide exceptional care to all of my patients, regardless of their hue.
Yeah, and also thank you so much, Dr. Addae-Konadu. Fortunately, recently, Governor Newsom signed Senate Bill 464, written by Senator Holly Mitchell. This will require implicit bias training for all perinatal healthcare providers. This came after Serena Williams had a very tragic episode. She almost lost her life, quite frankly, while giving birth. And, but her story isn't uncommon, right? As a Black woman, I'm 2 to 3 more times likely to die from pregnancy-related causes than white women. And to make matters worse, because Serena was 36, she had a 4 to 5 times higher chance of dying, and she almost did. And I think what was very fascinating for me about Serena's case is that the disparity could not be explained by her education, her income level, her lack of prenatal care. She's a millionaire who's accustomed to receiving only the best life can offer. And at that time, her fame, her money, her zip code couldn't protect her. She came into the hospital bare, naked, and Black. And none of those other things could protect her. And so we're confident that there's a real problem here. And as medical physicians and other healthcare workers, we just really have to do the work. We have to take the trainings that are coming down everyone's pipe who touches pregnant women. We have to start questioning our own biases. My colleague said, it's nothing to be embarrassed about. If you have a brain, you have a bias, right? It's instant. But as physicians, it's our duty to care for every member the very best way we can. And so, that's what I would also say to that.
Thank you, Dr. Okonkwo-Holmes. I'm thinking about this and looking at the other questions, and there's a bunch of questions related to maybe different ways in which could experience bias. And so one of the questions here mentions about whether, and this is from Jenna Colazzo, thinking about whether you could speak to the prevalence of medical professionals gaslighting patients, specifically Black and African-American women, and how that could contribute, or its contribution to elevated rates of Black maternal mortality. Dr. Ray, do you want to touch on that point?
Yeah, we do have research, and one of the kinds of research I like are those that pair the statistical data with those with the testimonies as part of the way that I do research. And so we have that data and we have those testimonies from patients who say they're dismissed, right? They're told that it's all in your head. They're told that your pain's not that bad. They're told you're exaggerating, or they're thought to be just seeking pain pills, right? That they're drug seekers. So you have, it's definitely a problem, and it's one of the contributions to Black death, to put it frank, is that Black people often are not seen as trustworthy narrators of their own story, right? They're seen as people who lie or exaggerate the truth. And even we have data that says some Black people will bring white family members, particularly Black women who are pregnant. They will bring white family members, if they have a white husband or white in-laws or a white friend, to their doctor's appointments for validity, hoping that if this white person backs up their claims of pain, that they will be believed. And and oftentimes it does work for them. And Black people are very aware of gaslighting in medicine, and so they come prepared for it. And that in itself is a trauma. That in itself is an act of violence. And you have to ready your body, you have to ready your mind for the trauma that you're about to experience of not being believed or told it's all in your mind, right? So it's sort of like this double whammy when you're Black and you're a patient, is that first you have to prepare yourself to be disbelieved or be gaslighted when you go to see, when you have a clinical visit. And then when you're there, you have to sort of fight. You have to fight to be seen, fight to be heard, fight to be taken seriously, fight so gaslighting doesn't kill you, right? And so gaslighting, it is a problem in medicine. And then there's all these factors. We haven't talked about class a lot, but keep in mind, that it's all related: gender, race, class, all of those things sort of intersect to create disparities and to create silencing in medicine. And so, yeah, it is a problem. And that's one of the things where we have implicit bias classes to make people aware of these things. It's when we have checks and balances. It's when we have policies that say you will have repercussions and consequences if you do this. We have policies that are anti-racist and justice focused in these institutions. And this is what it takes to end unnecessary and preventable Black death.
Yeah, thank you, Dr. Ray, for that. I'm looking here and thinking about kind of questions. Maybe Dr. Addae-Konadu, if you want to take this one as well. I mean, this is kind of thinking about ways in which people can find, or the question, this one is from Ivana Randall, about where Black women can find, they're moving toward learning about holistic resources because of the safety they feel, or the lack of safety they feel in the medical system and its treatment of Black women. So she's mentioning about doulas and midwives, and what are your opinions on them, about people thinking about other sort of ways in which they can maybe find kind of trust in medical system.
So I'm totally in support of having a doula with you present. That, especially labor can be a very stressful time. Things can change very rapidly, and having an advocate in the room that can speak for you or can communicate for you when you are in a position where you can't, I would always advocate and support that. I love our midwives at Duke. They're amazing. They are some of the best laborers out there. And so I'm totally in support of that as well. As far as resources, I don't have any resources specifically, but patients that I've talked to in the past will, go online and Google and try and look for doulas in their community and interview like several doulas before deciding on who they think would be like a best fit for them. So I would always be in support of that.
Thank you. There's a couple of questions here about the kind of the toll that bias takes on healthcare providers and experiencing that. And so one question from an anonymous attendee is talking about, well, how difficult is it to block kind of negative feedback or the experience? I think a couple, Dr. Addae-Konadu, you had talked about the anxiety that comes along with thinking about this, or the sort of impact for people, women of color who are practicing and thinking about, and I think wondering maybe to hear a little more about that, but maybe also what you do to overcome that.
Yeah, I think there are a couple of strategies you can utilize. And thank you for that question. It's an excellent one. I think one of the strategies you can use is bystander skills. So which are ways that you can intervene when you overhear or anticipate receiving a harmful comment or action, which can contribute to a climate of exclusion. So if it's not directed at you, but directed at someone around you, interrupting that exchange. Let's talk about something else, or change the subject, or sharing a story about a painful impact of a similar comment or action, like being confused for or referred to by other minority providers in your group, or asking questions that reveal like why the comment or action could be harmful in a non-confrontational way. Like, can you help me understand your comment, or why you feel this person is not qualified for their role, or why they're not thorough in their approach? I think the other biggest thing, and one approach that I utilize a lot, is emotional intelligence. the ability to understand and to manage your own emotions and those of people around you, which includes knowing how you feel in a given situation. That's having a keen sense of self-awareness, understanding what is triggering your emotion and what it means to you. So having like internal self-regulation and understanding how your emotions can affect other people and how other people's projected emotions toward you makes you feel. And I think, the biggest thing is important to remember, you have the power to choose how you react to your own emotions and the emotions others project toward you.
Yeah, I think, thank you. I think to piggyback with what Dr. Addae-Konadu said, it's so unfortunate that before your prefrontal cortex does all of those wonderful things that Dr. Addae-Konadu mentioned, unfortunately, all that pain has to go through your limbic system, right? And the limbic system is so powerful because it's so responsible for just sort of feelings and emotion. And, people often wonder, why am I taking it so personal? Why do I feel so sad about it? And again, it's because, whenever we talk about inclusion, we have to talk about exclusion. Anytime you exclude anyone, and, I can tell you that in talking to so many Black women, they feel that they are excluded on their teams, or that they're invisible, or that they're treated differently. Fortunately, I have a wonderful team at Family Medicine here at Kansas City, and I can say that I really feel a great sense of belonging. But what happens when a person does not? That is, of those 2% of Black women physicians, or even 2% of Black men, it really activates the area in their brain, the amygdala, that same area that's responsible for pain. So it feels like a stab, it feels like a pinch, it feels like a scrape. And people often wonder why they're in so much pain. It's the same area. In fact, I advise them to go home and take a Tylenol. And so we really have to be careful about that. And if we look at it at a more deeper, and we think about the DNA, our DNA, the ends of our DNAs have these beautiful long telomeres. They're long and they're flowing and they're lubricated, and they are responsible for our longevity. And what we find is that Black women specifically, we're aging 7 years faster than white women. Our telomeres are shortened by the time we're in our mid-50s. Well, why is that, right? Why is that? And that is because these biases, these microaggressions, these being passed up for opportunities or being passed up to speak, or when it happens to you, and I can only say it, and many people know what I mean. It happened to me today. And you can't always describe it, you can't prove it, but these things smash our telomeres. They literally begin to pluck away at them. So exclusion is not just unkind. It is very dangerous to our existence. It's very dangerous to our existence, and it increases our mortality. It decreases our lifespan.
I mean, just to comment on what Dr. Okonkwo-Holmes just mentioned, those strategies that I talked about is not something that happened overnight, right? It took a long time to get there. It was emotionally draining and exhausting, talking about a death by 1,000 cuts, going through the things that you experience as a woman of color in academics. But unfortunately, I think, it's the stance that a lot of minorities take to survive in a majority institution. And it's a skill set, that I learned in residency, that took me time to learn over the 4 years of residency, and that I was able to carry, into fellowship, and actually I challenged the audience tonight to really think about, ask your minority colleagues, how often do they think about race? As well as to ask the question of yourself, how often do I think about race? Personally, it's something that, I am acutely aware of in every environment I enter, whether it is going to the grocery store, whether it's walking on labor and delivery, whether it's going into the clinic. I am always aware that I am a person of color.
I'm aware of that fact every moment of my life.
Agreed, always, especially if I'm in the classroom, right? sometimes when you're an educator and what you educate or what you research on is issues of race, sometimes people will say, well, obviously you're going to research that. Obviously, that's what you do. So sometimes the validity of your expertise is questioned. Sometimes the validity of your teaching experience is questioned. So it becomes very apparent that you are different, or you're in a space where you see you don't belong when you're in front of a classroom.
I love the story of Brent Staples. Dr. Cloud Steele, he's from Stanford University, and he talks about Brent Staples. And Brent Staples was a University of Chicago graduate, very tall Black man, walking through this campus. And he found that the looks he got, the fear that he invoked just by his stature was so painful and hurtful for him. So he had to come up with a method. And what he did was he taught himself to whistle Vivaldi and to whistle Beatles tunes. And so I love that story because I really love Vivaldi. The majority of us have listened to Vivaldi while we're studying or in an elevator. But here's a technique that this big man had to teach himself in order to feel that he belonged, in order to get away from that vicious stare where people just like cross the street as soon as they see you coming. Imagine that being your life, that every day when people saw you, they found you to be an aversion. And so he taught himself to whistle Vivaldi. And so it's very interesting. And it's not just difficult for us as Black women, it's difficult for many people. It's difficult for many people, and that's something that we can all agree on. This transcends race. This is about ethnicity. This is about religion. This is about sexual identity, gender orientation. This is about someone having to stop wearing their hijab after 9/11. It's not just happening to me and Dr. Keisha and Dr. Kateena. There's a much bigger picture when we talk about inclusion and exclusion, when we talk about biases, right? In fact, when you take the Harvard Implicit Association test, you'll find that the two biggest ones were tattoos. Most Americans have a huge aversion to tattoos, although most Americans are tattooed right now. And the other one is weight and age, okay? And so it goes beyond us, and I'm just grateful that we have the opportunity to share our stories today.
Yes, thank you, Dr. Okonkwo-Holmes, about that. And I think one important question here, looking at the queue of the questions, is thinking about, so we talked some there about strategies that you all use to deal with those sort of biases, but one question, this one's from Benjamin Levi, is thinking about, well, what should other people be doing to think about this? So his question is, what recommendations would you give to help all involved avoid putting the onus on people of color to be the ones to identify implicit bias and its impact? And so people like me, what we should be working on here. Dr. Ray, do you want to take that one?
Sure, yeah, sometimes it feels very simple, and sometimes I think it's not as complicated as we like to make it out to be, and that is do the work yourself. I think right now there is so much information on implicit bias. There's a lot of information on fat phobia, transphobia, racism, sexism, there are ableism, right? We have so many scholars putting out scholarship, and also scholarship that is attainable, right? Not just written for other academics. And so doing the research yourself, not relying on your friends of color or your friends with disabilities or your transgender friends to educate you, but to go out and do the education yourself. And right now, as far as resources, there really just is not an excuse for it, because there are tons of resources there. Simple Google searches can help you, right? So, and then actually, when you're in these spaces with your colleagues and you see something that is wrong, say something. Your friends, your colleagues, your family will appreciate it. There have been many times when I've been in a meeting, the only Black woman, and I'll say something and it gets silenced and ignored, and someone else will say the exact same thing and get praised, and another colleague will say, wait a minute, Keisha just said that, let's let her finish, right? I appreciate those moments from my colleagues that help me in those moments. And so if you see something wrong, say something. Don't just sit back and let it go. And that's one of the things that I think it can be so powerful, is just being there to help, but doing the work yourself and not relying on someone else to educate you. It's not their job. If you're in academia and you invite speakers for their education, properly compensate them, make technology available to them, making sure that they have the space to do the job that you've asked them to do. That's something really important too, to not use Black scholars or not to use scholars who have disabilities for the information without properly recognizing them. Appointing people of color, appointing people who are different to different committees, right? And then giving them the recognition and the resources to do that work. So it requires, like I said earlier, it requires a dedication. It requires a commitment to diversity and inclusion, not just diversity, but the inclusion part, right? The retention part. And sometimes that requires you doing the work and then making the work speak for itself, making it shown that you are here to make a difference.
Absolutely.
Thank you, ladies, so much for sharing your thoughts and your insights. And thank you for all the questions. If we didn't get to your question, feel free to reach out to the KIE later to continue the conversation. We're going to have events like this again. And also, if you are just not joining or you didn't catch the beginning of our conversation, we might have answered your question in the beginning. Our recording will be available. Dr. Burrows put that link in the chat as well, so you can all access this recording after the fact. But ladies, is there anything that you feel we didn't touch enough on, or anything you'd like to share with the audience? The floor is yours. We're wrapping up here, gonna end in a little over 8 minutes. So by all means, whoever wants to go, Dr. Kateena Addae or Dr. Keisha Ray or Dr. Okonkwo, whoever would like to share some final thoughts.
I'll share a final thought. I think it's really important to just note that it's not just about race, it's not just about gender, it's not just about class, but that when we talk about racial disparities in health, when we talk about Black women mortality rates, maternal mortality rates, as we've talked about, we talk about Black women dying sooner than their counterparts. When we talk about just overall lower life expectancies, that it is a combination of inequities and social determinants of health. It's inequities in housing, inequities in access to clean air, clean water, environmental injustices. It's inequitable access to technology, to transportation, right? To buses not going to certain people of color neighborhoods certain times, or Ubers and Lyfts charging more when they go to neighborhoods of color, right? It's a larger problem. It's not just about inequities that happen in healthcare or when a person steps into a clinical setting, but that the inequities that they face before they get to the clinical setting can have a great impact on their health outcomes. And I just want to stress that it's not just about solving provider bias, it's about solving social inequities that people face before they even get to see a provider.
Absolutely. To follow up actually what Dr. Ray just said about that, in my research, I actually got to work with the founder of the Duke Midwifery Program, Amy McDonald, and she is someone who I consider one of my foundational insights into my paper, because she did touch on exactly that, the bias that a person can encounter on the way to the doctor. Also, as a rural sociologist from Ole Miss, also helped me in my research about that and gave me a little bit of background on what it could mean to be someone who might have an education but just live in a rural region, and you might have less access to resources. And I really appreciate the conversation tonight that talked about resources and how some people may not have access to it, and that can impact the way that you're treated by others, regardless of your race or your ethnicity. Dr. Kateena Addae-Konadu and Dr. Okonkwo, did you professors have anything you wanted to share?
I mean, I think Dr. Ray, that was an excellent summary. So I don't have any like additional things to add, but I just wanted to say Amy McDonald, I'm so glad you brought her up. She is one of the most compassionate and amazing midwives I've like ever worked with. She is a phenomenal human being. So I echo everything you said about her, Brittany.
Yeah. I would just say that I see that in the chat there are women who are up and coming, you know, you're going through it or you're in it. And you're wondering if you're ever going to get up here. And I just want to let you know that you just have to keep climbing and you have to keep believing in yourself with everything in your being. And you've got to reach out for help when you need it. You don't have to be strong and do it all. It's okay to delegate and get help. And the other thing that I want to say is that, you know, so my husband's background is his family's from Mississippi down south, and Georgia, and I am still trying to sort of talk to him about getting the vaccination when it's his time. I, of course, leaped at the opportunity to do so. Dr. Tyler Perry has recently put out a special in the African American community, and I highlight Dr. Corbett whenever I can. But when I thought about my bias, when my bias at my disappointment for his not wanting it, I had to kind of really rethink things. And looking at it through his lens, you know, I decided, you know what, you know, my husband, you know, he's a descendant of Southern slaves. He's very much against the vaccine, and in his DNA lies instructions passed down from generation to generation. Undoubtedly, the mRNA transcribed the message to say, do not trust them. Them who stole your ancestors, who betrayed, who whipped, who raped, and denied, even when it was evident that penicillin worked to cure syphilis, continued to let someone's grandpa infect someone's grandma, and who would then die of neurosyphilis. So, you know, how do we as healthcare providers, you know, how do we undo the sins of our ancestors? And what is this story? And what is this story? And what is this? What is really reverberating in the DNA of many of our American citizens? And I just try to take time to really think about that. And rather than to impose my own views or my own wishes, I try to listen deeply and then answer as many questions and inform. You know, I realize that subconsciously, for him, something may be saying, run away, you know, run far away. If they say yes, say no. If they say stop, make sure you go. And at all costs, do not trust. So I think about all that's happened and unfolded in our community over the last couple of years. And I'm hopeful because we're talking about it. And I think that's the first step, you know, we're trying to understand each other, which is really important.
Absolutely. It's totally important. And this conversation was well deserved, well needed, and well attended. So I wanted to thank everyone again that came out. Dr. Olson or Dr. Burrows from KIE Institute, do you all have any final comments for our panelists and attendees?
I would just say thank you so much for your attendance this evening, for your wonderful questions. We apologize if we didn't get to your question in the queue. There were so many wonderful ones there, and thank you to each of the panelists. Right now, I'm going to put one other thing. This event is one of many wonderful events that are happening at CSUB this month. And this list of events that are here for Black History Month at CSUB, I just put in the chat for you all. You can see other things that are coming up in the next couple of weeks that will be all wonderful things for you all to see. So thank you to each of you attending and each of our panelists for your thoughts this evening. And thank you so much, Brittany. I think you should have the last word here, Brittany.
Brittany.
Oh, well, thank you for that honor. I just want to say this panel was sort of one of a dream of mine to put together. It was sort of a project that was just birthed a couple years ago when I was meeting with one of my mentors, Dr. Michael Burrows, and I told him I want to talk about health and disparities. And you know what, I'm a Black woman, so let's throw that in the mix as well. And then COVID hit, and it was just like, wow, this is like so timely. And thank you to Kaiser and Brooke for saying, you know what, we have things that we want to share. We have all these people, amazing people that want to jump on. And Dr. Okonkwo-Holmes came on, and Dr. Keisha Ray, who was also part of our first speaker event. Thank you. I feel so honored. And then my other mentor, Dr. Kateena Addae-Konadu, just sharing her insights. It was such an honor to speak with you and just talk about something that is impacting so many people. And I just wanted to say thanks and have a great night.
Thank you. Thank you so much. Good night.